And our next speaker is Professor Rashid Luqmani, and he is a distinguished and well-known rheumatologist in University of Oxford, and he is going to talk about tapering of steroids in ANCA-associated vasculitis in clinical trials and real life.
Thank you very much, and thank you again for the invitation. I think we're probably running a little late, so I better hurry. And I'm going to talk a bit about steroids and in the context of ANCA vasculitis. This is a complex area. I've shown you a picture like this in the last talk just to remind you that we are attacking many mechanisms. We are using a cocktail of therapies at the moment, and the one we're going to focus on is the role of corticosteroids in all of this. There is no doubt that the combined package of standard immunosuppression saves lives. And I've already mentioned that the survival within 1 year of using cyclophosphamide and steroid therapy combined for ANCA vasculitis will give you something like a 94% survival for standard disease. It's about 74% if you've got rapidly progressive renal failure and/or lung hemorrhage. So the patients needing plasma exchange, in other words, have a much worse survival. But no doubt, without that therapy, the disease would have a very severe mortality, as you can see in the red line, which is what happened without therapy. And in our approach to these patients, we don't all see them with vasculitis as the initial label. We have to work that out. We have to go through a diagnostic procedure in a patient with a multi-system illness. And at that time, you are worried about the patient. You want to start therapy. You haven't completed the tests. It's usually Friday afternoon. The laboratory is shut. Nobody's working. It's only you and the patient. And you often end up wanting to immunosuppress. And so what do? You give them steroid. You very often will use initial steroid therapy because you're worried about life or organ-threatening disease before you then undertake your definitive investigations. So that's normal life. Now that has to fit in with our EULAR management guidelines, and again, you've seen this picture already, and steroids are right in the middle. They are for the standard of care for combined with cyclophosphamide and or rituximab, or combined with methotrexate or mycophenolate for less severe disease, but they are key to the therapy protocol at the moment. And they, again, I've shown you this slide already, just to remind you that the complexities of managing vasculitis involve quite a lot of evaluations to decide when to use more or less immunosuppression. In other words, when to use more or less steroids or cyclophosphamide or azathioprine. Now, steroids work by two broad ways. There's a genomic pathway and a non-genomic pathway on the cell, and you can saturate these pathways with a certain amount of steroid. And it's my contention that we are probably overdoing it with our steroid use. And pulses of steroid, which are very much loved by physicians and rheumatologists and clinicians alike, I actually would differ very much. I very much don't like using pulse steroids. So you want to know my personal view? My personal view is stop using so much pulse steroid therapy, especially in ANCA vasculitis. I suspect in lupus as well, actually, but we'll get there. Patients love steroids at the beginning because they give them fast relief of their symptoms, especially at the right at the beginning, at the diagnosis. They're relieved at getting their diagnosis. They're relieved at feeling better. And then that pretty much starts having a problem because they get side effects, emotional, physical, and social side effects. And then they start getting worried about steroids, and then they start hating steroids. They don't love them anymore. And then you start hating steroids as well, because once you've got established disease, you've got fear of adverse effects, you've got fear of flare without steroids. It's like the devil. You've danced with the devil, and you don't know whether to let go or to hang on. So this is a steroid protocol-heavy example. This is Rituxvas. This is the protocol that we published some years ago 9 years ago in the New England Journal of Medicine. This was primarily to look at rituximab compared to cyclophosphamide in ANCA-associated vasculitis, and it was one of the two trials of rituximab. RAVE was obviously the main big one, and rituximab got published in exactly the same journal of the New England Journal. And essentially, we were comparing rituximab with cyclophosphamide, but everybody got steroids. And in the black arrow at the top, you can see pulse IV methylprednisolone was allowed as an initial therapy. And then the orange shows you the very large dose of steroid, 1 milligram per kilogram, and then stepping down and still being on steroids at year 1. So quite a lot of steroid use. Fast forward to 2019, and this is a yet unproven protocol from the Hammersmith Cambridge group proposing no pulses of steroid at all. Again, looking at the same cohort of patients, ANCA vasculitis. They've published this as a retrospective cohort saying, we're going to try this new protocol. We're going to use a much lower dose of steroid here. So you've got, although it looks the same, it's not. So you haven't got the pulse, and you've got a lower dose of steroid, and you've actually reached, I think by about 6 months or something, a much smaller amount of overall steroid. Good results, but again, it's an open label retrospective study, but it suggests that the way forward in these groups is less steroid. Now, you can potentially claim that this study from a couple of years ago from Ma and colleagues suggested some benefit overall in terms of patient survival without dialysis, with steroids on top of standard therapy on the curve B, but no real improvement in terms of overall survival, curve A. So pulse methylprednisolone, I still think the jury is decided it's no good. You think it's good, but actually it's a mindset, it's a historical problem. We have to look at the facts. The facts suggest there is no benefit. These are the ULR recommended oral steroid tapers starting at 60 milligrams a day and tapering down over a couple of year period. And that's what we published in the guideline in 2016. This is the Pexivas protocol. I mentioned Pexivas in the last talk. This is the plasma exchange study. And Pexivas is an interesting study because it's randomizing plasma exchange versus not for standard therapy for ANCA vasculitis, along with steroids and cyclophosphamide. But there's a second step randomization of high dose or low dose steroid therapy. So the high dose is the standard 60 milligram to 75 milligrams a day reducing, shown as standard on the left, and there's reduced dose, which is starting at 50 or 60 for the first week, but then rapidly going down to 30 milligrams a day on average, as you can see, and really significantly reducing the total amount of steroid burden. And the abstract from last year, although it said plasma exchange didn't make a difference, it did say also reduction of steroids made no difference. In other words, you can use almost a third to a half less cumulative steroid and still achieve the same thing as long as you're using concurrent other therapies. So you're using cyclophosphamide or you're using rituximab, you are getting effective control of disease. You do not need as much steroid as we used to think. There is clearly historically evidence that you do need a certain amount of steroid. And Mike Walsh looked at all of the UVAS trials and meta-analyzed 983 patients from 13 studies, suggesting that if you are using very low doses of steroids, you will undoubtedly have a relapse rate. And this primarily comes from a study where we stopped all therapy after 1 year, steroids as well as the immunotherapy, and we saw lots of relapses. That was the NORAM study. But 14% relapse versus 43% relapse in terms of long-term steroids at 5 milligrams a day is the price you pay. But of course, the glucocorticoid regimens in the trials we've done to date have all been a little bit variable. Now, I don't want you to read any of the text here. It's simply to give you a flavor for how variable the steroid regimens have been in all of these studies. These are just 4 examples. Here's another 3 examples. And you can see that they're all different. If they were the same, I would try and summarize how similar they were. But actually, they're actually quite different. So you've got to weigh up the risks of steroids against the benefits of steroids. We've already heard from the patient's voice about that. Here's the doctor's voice saying, I'm worried about diabetes and cataract and hypertension. All right, we get rapid oxidative action and control of inflammation, but actually you can do that in other ways now. And if you look at the long-term mortality consequences to having ANCA vasculitis, those patients who do die, in the first year, most of the deaths in the yellow relate to infection or active vasculitis. So infection very much relates to steroids. So you've got a real consequence to being on high-dose steroid. And in fact, this nice study from the Chapel Hill group at North Carolina show how any infection will have a huge adverse event and effect on control of the disease, and particularly risk of mortality. So letting people get infections by being on too much steroid has adverse consequences. We know, and we've published on this is the effects of damage. So this is the consequences of having had vasculitis to develop irreversible scarring, and represented by the vasculitis damage index. So these are the items from the VDI, low GFR, hypertension, proteinuria. Many of these are combinations. They are related to the disease itself, but some of them are purely steroid related. The osteoporosis, for example, and that's well brought out in GCA literature as well as in ANCA vasculitis literature, that you are doing your patient harm the more steroid you give them. So it comes down to trying to develop an evidence base for how we best manage steroids, where we put them in the induction protocol, where we put them in the maintenance protocol. Should we use them long term, or should we only just use them initially and rely on our other therapies, our other immune modulators to maintain? I'll skip that one. And I think this is the most interesting study I've seen recently, which is Ruth Pepper's study from the Hammersmith, where they gave almost no steroid at all to a group of patients with ANCA vasculitis. They aggressively used rituximab and cyclophosphamide, and then they achieved virtually no steroid at all in one of the protocols, which was just fantastic. And yet, we're seeing good results. So the second study I think you need to remember is the CLEAR study. This is a phase 2 randomized study from 2 years ago. The phase 3 has just finished recruiting. This is the complement inhibitor, C5a inhibitor, and they went to the stage of having a no steroid arm to control disease. So you're just using a C5a inhibitor very specifically, and no corticosteroid use. This is revolutionary. I think this is really good. So I think that steroids sit very much in the middle of this process of developing damage as a result of recurrent flaring of vasculitis, which is our current model. 70% of our ANCA vasculitis patients will flare. So you asked me personally what I do about managing steroids. So this is what I'm starting to do personally. So this is part of our database that we collect data on. We look and record how much we should be recommending for steroid use. We then can pull down this menu and enter the date of what the steroid data starting, what the dose that we're choosing to start at. We then, the computer will calculate the dates so we can have a more precise understanding of what we are planning to do. When we review the patients, we can actually look at the actual dose used, and we can pull across if the recommended dose translates to the actual dose just simply by clicking the buttons. And if the doses are adjusted because the patient took a different dose than you recommended, or the GP recommended a different dose than you recommended, then you can adjust that with the up and down arrows. And then the bottom line is you can calculate the cumulative exposure that you recommend, as well as calculating the cumulative exposure that the patient actually took. So that's what I actually do. So that's my very brief summary. I'll skip to the end because that just shows you a bit more. So steroids are used currently with most other immunosuppressive therapies in most forms of vasculitis. I think toxicity remains a huge burden. It's still a big problem, but more effective targeted therapies are on their way. They have been demonstrated to reduce the need for high doses, sometimes even eliminate the use of steroids at all. But I think that historically you've got to look at conventional therapies and say, well, you still needed steroids with conventional therapies. So if you're still using conventional therapies, and there will be patients in whom you have no choice, they cannot have the targeted therapy, they've got a past history of cancer or they're intolerant of the targeted therapies, you will be requiring longer doses and long durations of steroids. I've shown you my personal example of how I'm trying to regulate that by knowing what I'm doing, because very often it's very easy to ask the patient to take a certain amount and then you don't see them again for months for various reasons. They haven't come to clinic and you're horrified that they're still on 60 milligrams a day, and that still happens to me now. So I'm trying to do something about it. Thank you.
Thank you. Thank you very much, Professor Luqmani, for sharing us with your experience in managing patients with vasculitis. And if there is any question, please.
Yeah.
Yeah.
Hi. Thank you for the extra interesting talk. Ibrahim Maghlout, I'm an assistant professor in College of Medicine. I have a couple of questions. The first part is that although I totally agree on the toxicity of steroid, I think what we don't understand quite well, and I would like to hear your point about it, is the personal variability. We know from a biological perspective that people respond differently based on their glucocorticoid receptors. And that may take into account when we do a population-based inference, looking at the studies that you quoted. So that's number one. The second part is, what do you think about the use of pulse steroid without high doses afterwards? So some strategies would use the high doses, regardless how we define pulse, because of the way they work molecularly, rather than the high oral doses that accumulate over time. And these are the two simple questions.
So, I mean, in answer to your first question, of course, there's a bit of variability about how much steroid it takes to saturate any individual person's receptors. But I think your variability is perhaps around, I don't know, 40 to 100 milligrams of steroid a day. I think if you're going above that, you're probably not achieving very much. Now, remember, there's some old data looking at some patients with lupus who were given 250 milligram prednisolone IV for a flare of lupus compared to a gram. No difference. So I think that we are overdoing it. We have traditionally overdone it. And your second question was about how quickly
what do you think about the use of high doses,
sure.
high doses as a way to reduce the accumulative dose of a steroid?
Yeah, no, I think that's a good approach. So I think that if you can saturate your receptors quickly, then, and that's what Ruth Pepper was showing, and that's what that Steve McAdoo paper was suggesting, but again, that high dose doesn't need to be that high. So I think you get your saturation, and then you get out, and you put something in proper. And I mean, we had this debate a couple of weeks ago about what is proper, what should be there for ANCA vasculitis. And there's, a discussion that rituximab is what you need. You just need rituximab. But actually, if you've got organ-threatening or life-threatening disease, that takes weeks to act, typically 6 to 8 weeks. So you've got steroids coming in first, doing an initial attempt, and then you've got rituximab taking 6 or 7 weeks to work. So that's why in rituximab, we actually have a dose of cyclophosphamide, because I think that is proper. That is what's doing good very early on.
Thank you so much.
Thank you, Dr. Amer.
Thank you very much. This was really interesting, and we were really waiting for your answers and for your experience. Now, just I want to ask you from a total different perspective, is from a medical legal perspective. So we have many colleagues here who work in peripheral hospitals that are not tertiary care hospitals and might not have the huge experience with ANCA vasculitis. So now if a patient is coming with pulmonary hemorrhage or RPGN, everybody is really panicking. The whole hospital is panicking, not the physicians only. So what happens is that people give pulse because this is what the standard of care has been for decades, and what you consider the best you could give to a very sick patient who might die. So now for a medical legal issue, if a rheumatologist starts to reduce the steroid intake of patients, especially when they come with a flare or first presentation. How does this, for example, in your system in the UK, how does this translate if the patient, for example, deteriorates and dies or do not respond?
I think that's a really good point. And again, I think we should be going back to not necessarily what we've always been doing for decades, and therefore that must be right, but what is the evidence for what we are doing to be right or wrong? And probably the MEPEX trial provides the best evidence for that, because that was the trial comparing IV pulse steroid with plasma exchange on top of cyclophosphamide and oral steroid, and showed no benefit from the IV steroid. In fact, there were more infections in the IV steroid arm than there were in the plasma exchange arm. So I think that's an answer to justify medico-legally why maybe traditional practice of 3 or 4 pulses of IV methylprednisolone is not necessarily going to be the best answer. So I think that you will still find physicians who will still want to feel better because they feel they're doing the right thing for their patient, but probably you're not doing very much more than you would achieve by more modern means. And as we move and migrate towards much more targeted therapies, I think you will find that that traditional view that you need to get that methylprednisolone pulse in will hopefully be replaced by you need to get an expert in to give you the right advice, to get you the right treatment. I'm happy to start cyclophosphamide on Friday night before the biopsy is done. I'm much happier with that than to start the steroid at 3 grams over the whole weekend. I very often, I don't know if any neurology colleagues are here, but my neurology colleagues are conventionally giving me patients after they've given them 7 grams of methylprednisolone every day for 7 days. Then they call me.
Okay, we will take the last question.
Thank you for the interesting talk. The problem, the concern is to maintain remission. Relapses are the major concern. And we think that steroids are very important because in the mindset of physicians and patients, we have relapses because they're off steroids. Maybe this is not the problem that we don't have a good substitute. So the question is, can we go higher on azathioprine, for example, not only 2 or 3 milligram per kg, can we go higher? Would that help? And also for other medications, can we go higher to maintain remission?
I think that, again, that's a really important key point, and that's where we're going to make progress, is by understanding how best to use our other therapies. But probably the answer may more likely lie with rituximab, and using rituximab as your maintenance therapy at a programmed interval over a longer period of time, let's say 500 milligram fixed doses of rituximabs every 6 months. And the French group have nicely shown that up to 28 months that works well, and they're now extending that data for about 5 years and still showing that is probably an effective therapy. So you're changing from what used to be slightly inadequate therapies that needed steroids to top them up to much more effective therapies where you've got the answer right at the beginning and you're continuing to get the answer right as you progress, so that you are much less reliant, less dependent on the steroids. You probably will see less relapses as well as a result of those changes. By using more azathioprine, you will undoubtedly induce more cancers, so that there is a downside to the increase in azathioprine. It hasn't been properly tested in ANCA vasculitis, nor have the other therapies in terms of varying the dose. But interestingly, there was an earlier talk about mycophenolate saying it was, I think, superior as a maintenance agent to azathioprine for lupus. But in fact, in vasculitis, in ANCA vasculitis, it's the other way around. Mycophenolate's inferior to azathioprine in terms of maintaining relapses. So that suggests that different mechanisms are afoot. But again, we're talking about the period of time when we had rituximab wasn't really there, and these complement inhibitors weren't really there. So we're now moving into an exciting new phase where we now have the opportunities to be much more targeted, and I think there will be more targets unveiled.
Okay, thank you again, Professor Luqmani. And by the end of this